Welcome to the Healing Pain Podcast with Dr. Joe Tata. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tata.
Hey there, everyone. Welcome to this week's episode of the Healing Pain Podcast. This week, we're discussing pelvic pain and pelvic organ prolapse with Dr. Maureen Mason. Dr. Maureen Mason is a physical therapist with a board certification in pelvic healthcare. Maureen is the author of a new book called The Pelvic Rehabilitation Guide Across the Lifespan, published by Handspring Publishing. Maureen takes an integrative approach to her physical therapy practice, where she provides client care, teaching, as well as clinical mentorship in the San Diego, California area. On today's episode, we'll take a deep dive into pelvic organ prolapse, as well as pelvic uterine prolapse, and many other issues that intersect with pelvic girdle pain. We'll go over how to diagnose, how to treat, and how to manage this condition in the short, as well as long-term for women. Okay, without further ado, let's begin and learn about pelvic organ prolapse, as well as pelvic pain, with Dr. Maureen Mason. Hey there, Maureen. Welcome to the podcast. It's great to have you here.
Great to meet you, Joe. Thanks for having me on.
You're welcome. I'm excited to speak with you. It's a new topic this week, spoken about pelvic pain in men's health and women's health. I know we're going to kind of go really deep into a certain topic that you have some expertise around. You talk about it in a new book that you have coming out. And that's the topic of pelvic organ prolapse, which can be painful, as you know, and as we all know. But there's a lot to this topic, right? I think a good place to begin, because it kind of sounds scary to people, is, what is pelvic organ prolapse and what's the cause of it?
Right. So what pelvic organ prolapse is a lowering of the pelvic organs towards the base of the pelvis, the vaginal opening, and it's experienced by women. And what is lowered in pelvic organ prolapse can be the bladder, it can be the uterus, it can be the bowel, or it can be all three organs kind of descending down. And what pelvic organ prolapse is also is a hidden condition that it's still not really talked about and people aren't aware of in terms of preparation for childbirth and also the menopause transition. So when it is experienced, when pelvic organ prolapse is experienced, people are typically in shock, fear, and worry. So there's a very high emotional impact, as well as them feeling the shame and not wanting to see a provider. So it goes untreated and undiagnosed.
Mm. And what are the common symptoms that a woman would experience when this occurs? What would drive them, obviously, to start seeking help from a pelvic health physical therapist or maybe another provider?
What would drive them to see a provider for help would be a uncomfortable, odd sensation, typically of a bulge or pressure. And it might be a general sense down there, so to speak, where people aren't really aware what's going on, where it is. A lot of people are disconnected from their pelvis due to a sense of privacy down there, and they might not even know what's going on and live with this pressure and a bulge sensation for years. What really would drive them to see someone, though, is more discomfort, more heaviness and pressure. There's some heaviness and pressure. It's not typically described as pain, but it can actually become painful where someone feels like they just need to get off their feet. And then finally, their bladder might not empty. The bladder can kind of tip, so where the urethra comes out of the bladder, where the kind of like the straw of the bladder that empties, that can get a little kinked up and they can't empty their bladder. Also, they may have ability to feel like they need to use a restroom and push, nothing happens. What the heck is going on? And this is very distressing. And it can be dangerous too, because if the bladder is retaining, et cetera, in the bowel, and then as the uterus descends too, it can be very uncomfortable. And then intimacy functions are affected. Mm-hmm. So intimacy may start, there may be a desire for penetration, and there's what's called obstructive intercourse. So intimate relations, sexual relations, and then we have the effect on the relationships if people are unable to have intimate relationships. So there's a broad spectrum of what pelvic organ prolapse can create in terms of discomfort, driving people to want to or need to see a provider.
So you mentioned a couple of moments ago that there are these typical signs and symptoms, but that some people are quote unquote disconnected from their pelvis, which kind of sounds funny because we're all anatomically disconnected. But I'm wondering if you can just give us an idea of what you mean by one being disconnected from their pelvis and how that impacts, let's say, their care.
Right. So if we can imagine, typically when pelvic organ prolapse might start is it can happen postpartum, and a woman is nursing a child, she's sleep deprived, she may have some thyroid problems where she's just feeling off, she could be in postpartum depression, and she could actually be suffering from a little bit of perinatal trauma if the birth didn't go as she wanted it to. So we know that women can have a birth plan and think, well, I'm going to do it this way, and I'm going to have a natural birth. And maybe if they need intervention of different natures, they can just really be kind of in a numb state. And that's trauma. So we have perinatal trauma, and also the busyness of our lives. If someone is in the menopause transition, let's say they're a grandmother and they're caring for their elderly parents who are, almost needing a nursing home. I've certainly worked with many women whose prolapse came on while they were caring for their elderly parents, lifting them while they were going through this themselves. So they just didn't have time to think about it. It's similar to maybe the arch is hurting, people are walking far, they have to walk, and they just think, well, my arch hurts and that's just the way I am. Or the neck hurts, and my neck hurts because of my work and all my demands, and I don't have time to deal with it. So I think, like many health conditions, people can ignore it for a while, but then it can go from a chronic problem to something that becomes critical, that the body will start to give the person signals that they must see a provider. Mm-hmm. It becomes, that pain, alert, danger, have to pay attention, what's going on, what do I do? And then typically younger women, younger generations are more empowered to take a mirror and examine and look and say, oh, I've heard about this. My friend's talking about it, and I know what this is, and so on and so forth. So there is a generational difference historically of the older an individual, the more they might feel a sense of shame and disempowerment due to religion, cultural influences, and things like that. That's been my experience, that they'll actually say, I don't want to go down there. It's down there, and they're disconnected. And that can start with the OBGYN exam, where typically they were even putting like a drape up when they're examining the woman for the pap smear and things like that. And the woman's relying on the doctor to tell her what's going on down there. Am I okay? Am I damaged? What's going on? So there is a disempowerment when one receives a pelvic exam, typically so those are some of the very important biopsychosocial considerations that providers have to be aware of, as well as anyone from the general public listening to this, that it is normal for many women to feel disconnect. It's normal to not know what's going on. And it can be normal to ignore health conditions for a while too. So that can lead to even more trouble where they think, why didn't I come in before? Why didn't I see someone? I've been dealing with this for years. Yeah. So
it's a great explanation. And in there, you've already started to touch on a little bit of the cause or the potential causes of this. I've been kind of listening to them as you're speaking, but maybe you can, guide us to kind of the more common causes that might lead to pelvic organ prolapse.
Right. So the most common cause is childbirth. And that can be vaginal childbirth, but also with cesarean birth. A mother has endured 10 months of increasing pressure into the pelvic bowl, and the pelvic floor muscles can have some elasticity. And the uterus is an amazing organ that can, increase so many times in size and then shrink back down. But the pressures of the pregnancy and the direct aspects of the birth, whether or not intervention was needed, a larger baby over 8 pounds tends to put more pressure. We certainly have women that have 9 and 10-pound babies and multiple births. So birth number 1, number 2, number 3. And we celebrate resilience and recovery in the pelvic floor, that things can heal, things can move back up, pelvic floor muscles can get stronger with time. So pregnancy and the actual aspects of the birth and delivery, the birth weight. Also, when a woman is postpartum, if she's nursing, her estrogen cycle does not return until she ceases nursing. There's target receptors in the pelvic floor muscles and the pelvic floor for estrogen that help the strength. And women have testosterone like men, testosterone, progesterone, normal hormone cycling. When it's ceased, when it's temporarily or permanently ceased in the case of menopause, the pelvic floor actually gets weaker. So that's another cause, is the hormone changes. So we have mechanical effects and we also have hormone effects. And then another fascinating concept is the pressure systems or intra-abdominal pressure. So some people are always clearing their throat. Or even when they talk, they're pushing down into their pelvis. And then women are lifting babies, older women are lifting suitcases. For life, we need to lift, push, pull, carry objects. Some people, when they lift things, they push down and they firm their abdominals, but they create a pressure downward. So this is called intra-abdominal pressure, and intra-abdominal pressure regulation is very important. And if we consider someone with asthma and a chronic cough, chronic bronchitis, even something like food allergies, where they have a lot of phlegm and they're all the time throughout the day, that actually can cause a little aggravation of a prolapse over time. So that's another thing to consider. And in the past, and still at this time, current time, we have told women, do not squat, do not lift. Well, a woman's got to lift a toddler in a car seat, and the toddler might be 30 pounds and so on and so forth. So it's like a woman has to be a CrossFit trained person and lift a baby and carry them and this and that, and even carry 2 toddlers sometimes. So we know with biomechanics that optimally, when we lift, push, pull, or carry, the pelvic floor engages, the abdominals engage, and the back, and the whole fascial body engages. We're not just lifting with our pelvic floor and our biceps. So personal training, having people learn to use all their muscle units in synchrony for lifting, pushing, pulling, carrying. Maybe they went into pregnancy and all they were doing was a little bit of abdominal tightening when they lifted. And then their pelvic floor can be actually turned off postpartum. It just stops working. And so they might need to retrain it. So intra-abdominal pressure regulation is a big factor to consider, which is fascinating because if someone strengthens their pelvic floor with exercise and they get stronger, that can help the prolapse. But if several times a day or all day they're coughing, clearing their throat, et cetera, that's a problem. And then constipation. And bloating, that puts pressure on the pelvic floor. And many times in the world of pelvic therapy, people can have prolapse and no one's talked to them about their nutrition, fluid and fiber management, basic things. And busy moms sometimes might not have time to poop. They might be so busy running around, they might ignore their own signal. For example, you've got 2 kids, you're going out the door, you might need to go, but elementary school starts in 10 minutes and you're 8 minutes from school, and your child says, Mom, I need to poop. So, all right, hurry up, kid, So, and at work also, people in business climates where they can't use a restroom, very common. Medical providers are notorious for this, for not using the restroom because of our busy schedules. So, and then a full bladder, if the bladder's being kept too full. And then the menstrual cycle affects prolapse too. So when a woman goes through ovulation, let's say she's postpartum, she starts her cycle again, and she's ovulating and having a normal cycle. There's 2 points in the menstrual cycle where women can actually experience prolapse, or it can come back a little bit and then it goes away. So we celebrate a resiliency model on prolapse. And when someone can find out and be a detective with a therapist what is causing this and look at all the drivers, then they're on empowerment, the road to empowerment, self-control, having some control over it, that sort of thing. And then one other thing, Joe, per your question on what causes it, obesity has been linked to prolapse, but we don't want to have people consider they just need to lose weight and it'll go away. There's certainly underweight individuals with prolapse, as well as individuals with more lax or loose connective tissue. So those individuals, even in a study of twins, one went through pregnancy and the other was a nullipara. She hadn't had kids. And these 2 women were examined, these twins, and they both had the same degree of prolapse. Mm. So not only pregnancy and menopause transitions, but connective tissue differences can be part of the picture too.
Let's talk about diagnosis, and then we'll kind of venture into the treatment. So I'm assuming the diagnosis will be a little bit shorter. Let's do diagnosis first. How is this condition diagnosed by various professionals out there?
Right. So the diagnosis for pelvic organ prolapse is via a urologist, gynecologist, or urogynecologist. It could be an internal medicine doctor as well if they're doing a pap check or that sort of thing. Any medical provider. It could show up in the emergency room. A nurse practitioner, a nurse, community health clinic, physical therapists make a musculoskeletal impairment diagnosis. And we can look at, there's a visual inspection. Is anything bulging beyond the vaginal opening? Or if the woman does a bear down maneuver, so-called Valsalva, breath hold and bear down. Some feel that's somewhat of a false test to just have someone bear down and do a visual inspection, because people are so used to clenching. If they have prolapse, they might not bear down. They're on their back. They're doing something for a provider to check something that they feel shameful about. And what might happen later in the day when they've been up all day, we wonder what happens in standing. It's all about standing and function. And the diagnosis, if we get into more specific details of a diagnosis, there are grades of prolapse. And those are based on how many centimeters the organs are moving downward towards the vaginal opening. It's technically called the hymen area, which is a vestigial area of tissue just inside the vaginal opening. And it can be 1 centimeter from it, or it can be 1 centimeter up to it. It's a stage 1, stage 2. And a stage 2 is starting to come out a little bit. In stage 3, things are out. In stage 4, it's completely out. And we can think of this too like a hernia. A hernia can just be someone can lift something really heavy and a male might feel it in their groin, and it might come and go. Or it could be the GI system's cramping and they need to get in and see someone. So It's diagnosed by a POP-Q, is the pelvic organ prolapse quantification scale. It's called the POP-Q. And those are really done by urogynecologists. And that's a staging technique to determine, make a decision on what type of care would be needed from there on.
And then what does treatment look like for those various stages?
So treatment, really, there's a big wheel of treatment that can be done. Surgery is sometimes necessary, but we might consider surgeries not considered actually until a woman's done breastfeeding, a year. So we might have someone in postpartum and think, oh my gosh, I got this diagnosis, I'm in for therapy, but I think I'm going to need surgery. And if they're nursing, and what about a woman that decides I'm going to nurse my child for 2 years? So with education on how long the cessation of estrogen is going to be present and how that might affect the pelvic floor, that's something an individual needs to consider. But the first line of treatment, according to the International Urogynecology Consensus that was published by Carrie Bowe and others in 2022, first line of treatment should be pelvic floor muscle training. It's the number one thing that's helpful. And there's a lower grade of prolapse in those that have stronger pelvic floor muscles. That being said, pelvic floor muscle training is not so easy to do. 40% of individuals cannot correctly engage their pelvic floor. They might actually bear down and make it worse. So if someone just tries at home, unfortunately, to do a whole bunch of workout things for their pelvic floor, they might actually be aggravating, and they might think, well, pelvic exercise didn't help. So if possible, to see a pelvic specialist, physical therapist for training in this. And we have the biggest studies done in the Scandinavian countries because they have socialized medicine. And there they see them for at least 8 visits, making sure they do them correctly. Why? Because sometimes people do them correctly, pelvic floor muscle exercise, also called Kegels, but I prefer to say pelvic floor muscle exercise. They can do them correctly, and then they can get off track, similar to physical therapists working with someone with engaging their rotator cuff. They might be engaging it correctly. Next thing you know, the trapezius is pulling the shoulder up and they're doing it incorrectly. So exercise is conservative care. We also have estrogen therapy, hormone replacement therapy. It's lovely. I was naive as a young physical therapist thinking, hoorah, Kegels, I'm going to fix this prolapse, help this patient. And we really we boot camped them with a pelvic floor exercise, and they got somewhat better, but they were nursing and still having problems. And then 30 years ago, this was for me in my practice, there came the hormone therapy, and there went the prolapse healing, and the woman returned to powder puff football, which she wanted to do. Women's playing football and lifting her baby and things. So we don't want providers to put themselves in a box and say, I've got the only thing, which happens in the medical field, also in the allied health and fitness trainers saying, you have to do my program. So, we need the doctor to prescribe estrogen and dose it. And sometimes it's as simple as twice a week estrogen use topically. So the other thing is pressure management, as I discussed. And some people might really be consuming too much dairy and have a sensitivity. And once they taper down on that, or maybe just go to some hard cheeses, they stop all the throat clearing. Asthma and allergies, there's many things that can be done. Sometimes there's environmental influences on that. Some people are sensitive to wheat. And again, the throat clearing and things like that. So fluid and fiber management is huge for optimizing function. And people say, well, I eat an apple and I have a salad. And so great that maybe they're consuming 8 grams of fiber a day. And we know the guidelines are 20 to 30 grams. I went through this myself as a healthcare provider. I thought, well, I'm having salads. And it's really simple to add one new healthy thing a week to help the GI system, as well as maybe some elimination. So, because aside from constipation, bloating. So bloating, people just say, this is how I am. This is how I am. Bloating is pressure. It's a lot of pressure. If one actually observes how much their stomach, their lower abdomen can distend, this is happening on the pelvic floor as well. And at the base, we have the uterus, the bladder, and the bowel. And then another conservative care aspect is pessaries. A pessary is like an orthotic in a shoe. Someone's going to go out for a run. They're not going to wear their sandals. They're going to get their best shoes. And so a pessary is typically a silicone device, like a little disc, and that is custom fit, and it is inserted in the vaginal canal, and it's placed high up enough to support the bladder, to help the uterus to not fall down, and the same thing with the bowel. The pessaries tend to work best for bladder prolapse, and the uterus are a little more difficult for the person with the back wall coming down. So, but what people need to know about pessaries for conservative management is typically it takes a fitting and trial of 2 to 3 different types. These are to be prescribed and monitored by a urogynecologist, and some pelvic health therapists in training with urogynecology are fitting pessaries. There can be an aggravation and irritation of the tissues. And the pessary, interestingly, it has to be big enough to keep things in, but not so big that one can't remove it. It's like the orthotic that goes in the shoe that just doesn't fit, and you can't get it in your shoe, and it's pushing your foot out of the shoe. So it's nice to think of as an orthotic. And then women with comfort with self-palpation, examining and putting the pessary in and out, there's pessary removal tools. A woman might actually take a pessary in and out on her own every couple days or leave in. We do know from research a year's worth of pessary use can actually reduce the stage of prolapse by 1 stage. So that's long-term use. Some women that have difficulties with insertion of a pessary and removal, they might actually keep it in for a month, and they go into their urogyne once a month and have the pessary checked, in observation of the tissue, make sure there's no irritation of any of the tissue, and so on and so forth. So those work. Usually they can help in conjunction with estrogen therapy for some people. And there's perhaps 20%, maybe even 30% that just don't tolerate them. And then we have, before we get to surgery, there's one more thing that could be helpful for people, and that's manual therapy. So what manual therapy is hands-on techniques to assist externally. For example, let's say someone has a cesarean scar and there's a little stiffness inside where the bladder sits. And the bladder, the front wall of the pelvis where the bladder sits, the bladder can't move up and down. So manual therapy combined with visceral therapy, internal, can actually help the bladder glide upward. Same thing with the uterus, same thing with the bowel. Now, if there's scar tissue from, let's say, an episiotomy, which is an incision that was made to assist with the birth, we could consider that episiotomy could be a stiffness spot that's holding things down and pulling down on, let's say, the back wall. So manual therapy can glide, have the person contract and relax and help the stiffness of the tissue and allow things to glide upward. So someone's trying to contract their pelvic floor. Imagine they have a cesarean scar, and maybe they had an episiotomy from another birth. These things are all a little bit like anchors dragging down. And then we have wonderful research that's new on this approach called biotensegrity. which looks at kind of like the geodesic dome, Buckminster Fuller, but that's throughout the whole body, our myofascial networks. The bladder is not just suspended by one thread like a piece of yarn. Same thing with the uterus, same thing with the bowel. So biotensegrity really looks at the rib cage, how everything's working, the abdominal wall, same thing with manual therapy. So these are specialty treatments. And then we have surgery for pelvic organ prolapse. And the surgery can be successful. We know some people might be, for example, a triathlete, and they might not want to deal with conservative care. Maybe they have their strength. They don't have really constipation or anything like that. And they have a surgery and it can be successful. However, there is, unfortunately, a repeat surgery rate between 20 and 30%, and that can be within a few years. And I do want to mention mesh, because mesh has been in the literature. Here in America, we see ads. Did you have mesh? Did you have mesh? Well, mesh, the wrong type of mesh was used for several years. It was an experimental type of mesh, and it didn't allow the myofascial fibers to engage in it. And the body kind of made a big scar out of it. So that's something that people hear about. They're still going to hear about, I can't have mesh. I can't have mesh. Well, our pelvic floor organs and the myofascial tissue, they are somewhat delicate tissues. And in many cases, mesh has to be used. And the American Urogynecology Association about 3 years ago made a statement that mesh is safe to use in the hands of an experienced provider that's an expert with it. So I want people listening to this to know that if you're going to have a surgery, and hopefully you've experienced conservative care that can help set you up for an excellent surgery, mesh can be part of surgery and it can be helpful.
Maureen, it's been great speaking to you about pelvic organ prolapse and the ways to diagnose and treat, and of course, all the education and learning around it. I know a lot of this you have wrapped up in a new book. So if you can tell us the name of the new book and how people can learn more about you.
Thanks for asking that, Joe. I had a calling to write a book, and therapists over the years kept asking me to write one. And finally, the publisher approached me, Handspring Publishing, a wonderful publishing house, and they're now a Singing Dragon also. So Pelvic Rehabilitation, the Manual Therapy and Exercise Guide, is now available at major booksellers. There's a Kindle version as well. And that book goes through the basics of how our pelvic floor muscles work and what we need to do for how the bladder works, how the bowel works, how the muscles work together. And there's a chapter specifically on pelvic organ prolapse in the postpartum challenges. So people can look up the book, and it's great reading. People are loving it. It's for the public, as well as healthcare providers are buying it for themselves in their departments. And I have centralstationwell.com is my website. And I will have some information on prolapse up for people for more detail. And there's wonderful exercises too that some women can do, some decompression, cat camel, and then down dog and these sorts of things, or elevate their hips and build up to weightlifting, that sort of thing. So I have the whole exercise series, not the whole, but an outline of an exercise series that can be in there, as well as hypopressive exercise. And that is a different way of breathing and engaging the pelvic floor that really takes some training. So, yeah.
Great. So I recommend everyone check out the book. It's called Pelvic Rehab, the Manual Therapy and Exercise Guide Across the Lifespan. You can find it at most major booksellers such as Amazon. And of course, you can check out Maureen on her website. If you need to access any of the links that we mentioned today, you can, of course, go over to the webpage at the integrativepainscienceinstitute.com, scroll over to podcasts, and then scroll down to this episode on pelvic organ prolapse. At the end of every episode, I ask you to share this information with your friends and family on Facebook, LinkedIn, Twitter. I'm on Instagram most, so you can find me at drjoetata.com. I'd love to see you there and to connect with you and connect with Maureen. I thank you all for being here, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tata. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.